There are a lot of acronyms in the world of fertility and fertility treatments, and today we're talking about one related to IVF called eSet, or elective single embryo transfer. Welcome to Lunchtime Live at the Center, where we talk about important fertility-related topics to inform and support your journey. My name is Ami Choksi, and today we're talking with our lab director, Dr. Alison Bartolucci, and she is here to talk about eSet, what it is, who it's for, why it's important, and answer your questions as well. Hello and welcome, Dr. Bartolucci.
Hi, thank you for having me.
Yes. So we mentioned eSet and what it stands for. So what exactly is it?
Right. So eSet, like you mentioned, it stands for Elective Single Embryo Transfer. We do love our acronyms. And that basically describes the process by which we are able to select one embryo for transfer to the patient, even though there are multiple embryos available. So that sounds kind of simple, but there is sort of a science really behind choosing that one embryo.
So there's a science behind it, and this happens in the middle of an IVF cycle, right?
Right. So patients that undergo IVF, it's very common for them to produce more than one or multiple eggs, which results in more than one embryo growing in the dish. And that's a good thing. But we know that not all of those embryos have the same potential for making a baby. So, and the tricky thing is that it can be hard to tell which embryos are which. So which ones make the babies and which ones don't. So oftentimes patients will have 2 or 3 embryos transferred, and the hope has always been there that one of the ones that was selected will be the one that makes the baby. But of course, the risk is that the patient may end up with twins or triplets by doing that.
So after a retrieval, this is when this happens, how does it work? How do you decide which embryo to choose? And we'll start there.
Yeah, so this typically happens on day 5. So the day of the patient's retrieval is day 0. And so these embryos have been growing for 5 days. And that's important because that's given us a lot of information to kind of use to be able to select the best one. And this whole process happens in the IVF lab. And the embryologists are the ones ultimately that have the privilege of choosing the one embryo. So what they do is they use a very comprehensive scoring system. So they look at the embryos down the microscope and they assign a score to each embryo. And that score has 3 points to it. And each point describes a characteristic of the embryo. So we're looking at the way that the embryo has grown, how big it is, how much it's expanded in size, as well as some real specifics about the quality of the different cell types that make up each embryo. So they do that for each embryo in the dish and essentially assign like a ranking system. And that's how they're able to choose the best one.
Now, does everybody do this, or only some people? Who would be a candidate for this?
Only the embryologists, but they are all very special people. So all the embryologists have been trained some of them have been trained for 30 years. But this is what, I mean, I think I speak for all of them when I say that it's the best part of their job, being able to look at embryos and say like, oh, that's the one. And apply that system, that morphology grading system. So yeah.
And the word elective is in this acronym. Right. Does that mean that it's an elective procedure, or it's elective, or is this required, or is this what happens here?
Yeah, so elective the word elective, I guess it depend how you ask, but the way we interpret that elective is that because there are more than one to choose from, that's why it's elective. So if for sometimes patients just have one embryo, and you can't really call that an elective single embryo transfer because she only had one. You didn't have to choose. But the other side of that definition is that it's, an option.
Mm-hmm.
It would depend on the patient's age. I know, here at CARS, we feel very strongly that our goal is not only to help patients get pregnant, but it's to help patients get pregnant with a safe and healthy pregnancy. So for patients who are less than 35, it's not a mandate, but there is a very, very strong recommendation to only transfer one embryo because their likelihood of getting pregnant is so high. I heard one doctor that I used to work with said you don't want to overprescribe embryos. And that can be the case for patients who are younger, for sure.
Okay, so we do this to ensure a singleton pregnancy as opposed to multiples. Is that the main reason?
Correct. Yeah. So the whole goal of an eSet is to transfer one embryo so that that there's only going to be one baby. So we want our patients to have one baby at a time. So that's the goal, because we know that there's so many complications associated with pregnancies that have twins or triplets.
Is this something that insurance recommends? Is that something that comes up?
Yes, I do. I think there are some guidelines for insurance companies where, again, because they know the risks involved with twins, that they really want their clients to only transfer one. So I'm not entirely sure, but I do believe that the insurance companies are getting more involved in that decision and really strongly recommending a single embryo transfer.
So the majority of women under 35 do single embryo transfer, right?
Yeah. So at CARS, I mean, we are real leaders in this area, and for patients under 35, 93% are having a single embryo transferred, which is really outstanding.
So 93%, as you just said, of the centers. So of those that are live births, what percent are singletons then?
Right. So that was for the less than 35. In that age group, 95% of the patients who get pregnant have a single baby, have one healthy baby. But overall, across all age groups, 85% of our births are a singleton delivery.
Oh, wow. Okay.
Yep.
And is this something, so we talked a little bit about PGT a couple of weeks ago.
Right.
Is this something that we recommend? Is this go hand in hand with PGT?
Yeah, so PGT is an exciting sort of adjunct to the eSet story because although we really promote transferring one embryo in the younger patients, for our older patients, and older in this case is over 35, which is crazy, but unfortunately that's biology.
Right.
So in those patients, they tend to meet criteria to transfer more than one sometimes, because we know, unfortunately, that their embryos are more likely to have what's called aneuploidy, which is the wrong number of chromosomes. So in that case, for those patients, their likelihood of not getting pregnant at all often outweighs their risk of twins or triplets. But it's never 100%. So they still can get twins and triplets, and that can be even more complicating for older patients. So that's where PGT comes in. And that's exciting because if we can apply that technology, and that involves a procedure that we do on the embryos themselves, where we take just a few cells from the part of the embryo that becomes the placenta, and we send those off to a genetic lab, and they're actually able to tell us which embryos have the right number of chromosomes, so which ones are normal and which ones aren't. And when we know that, then we 100% can transfer one embryo, because what's so exciting is that the playing field is leveled at that point. So even if the patient is older, if we know that the embryo is what's called euploid or chromosomally normal, then we can definitely transfer one embryo. So we're expanding the population of patients that we can offer an eSet to.
Okay. Is this something that the doctor that's discussed ahead of time?
Definitely. Yeah.
Okay.
Yeah. So that's another thing that's really important in terms, from our point of view, is that it can be very stressful when you're in the middle of a cycle and you've had an egg retrieval and there's a million things happening, and then you come in 5 days later for your embryo transfer. You don't want to be talking about how many to transfer at that point. You want to have had this discussion and be prepared and have a lot of time to think about it. So our patients, before they even start their IVF cycle, go into it knowing how many they're gonna take back.
Okay.
Yeah.
There's a question here that says, doesn't increasing I think it's the number of embryos transferred, also increase the chances of pregnancy, saying transferring 1 versus 2? I do understand that there's a higher risk.
Yeah. So those statistics are getting smaller. When we first or tighter. When we first tried doing eSet or tried doing single embryo transfer, the caller is exactly right. We did notice a decrease in pregnancy rates, even though there was also a decrease in twins. And really it's because we were just kind of transferring it across the board, just transferring one embryo. But now that we know about embryo development and which age groups are better candidates than others for a single embryo transfer, again, in that young, less than 35 age group, there is no increase in pregnancy rate. There's only an increase in twins.
Okay.
Yep.
And another question, when the embryologist reviews the available embryos, what thresholds determine which embryos are discarded? My question isn't focused around embryos that arrest on or before day 3, but embryos that are graded poorly at day 5.
Right. So unfortunately, there are almost always embryos in the patient's cohorts that either stop growing or grow in such a poor manner that we know from our experience that they're not going to survive any sort of freezing or thawing process, or that they're on their way to arrest or the stop growing. So I'm just trying to look at the question again. So the criteria for that, we apply that same scoring system, and the embryos that have not expanded, so they have a really poor score for the expansion, or their cells have atretic or degenerative appearance, which looks like the cells are actually on their way to dying. Those will be the ones that are not frozen and discarded.
Okay. And this is usually done on day 5. Is it ever done before or after day 5?
It's almost exclusively done at day 5 or later. We even take them out to as far as day 7 to see if any of them will catch up. Them all to the end.
Okay. Yeah. I think there are no more questions there. Is there anything that we didn't cover that you wanted to share?
I think that's it. I think we've talked about it before. The embryologists, they're kind of this mystery group of people behind the closet, but they are a huge part of our success. So we have a lot to thank them for. And, we have been so successful at choosing embryos for transfer and offering single embryo transfer to so many patients. So even in the older patients here at CARS, for all age groups, we have over 60% of the transfers are with one embryo, an elective single embryo transfer.
Oh,
and that's huge. So, and they deserve all the credit for that.
That's amazing, actually.
Yeah.
There are two more questions, actually. So what if the patient understands the risks of transferring two embryos and would actually be hoping for twins? What happens?
I know we actually have heard, we get this question every once in a while, and we all, all of us in the lab most of us are moms, and we say, that's clearly someone who doesn't have kids at home. But it is, ultimately, it is your body. I think it depends on your physician. They have a responsibility as well to not put you at harm. And depending on your circumstance, they may feel as though it's a reasonable request to take more than one embryo because of some, underlying condition or previous cycles. Or they may feel as though I cannot, as your physician, transfer two embryos because I know that I'm going to be putting you at an enormous amount of risk of having a multiple pregnancy. So I would say that happens on the physician level. There is, we do have a policy of transferring one, but there are case-by-case situations. And, but I will say that they take it very, very seriously because, although they're cute, it's cute to see twins, but what a lot of people don't see is what happens before that. I mean, I don't know personally of any twins that didn't spend at least some time in the NICU as soon as they were born. It's a very high rate of, premature delivery and other complications that can be even more serious. So,
Okay. And this says, is eSet done on frozen embryos? So I think they're thinking this is a test.
Oh, well, we do eSets when we're doing a frozen embryo transfer. And because actually, when we were talking about PGT, those have to be a frozen embryo transfer because of all the timing that's required for the testing. So the embryo is biopsied and then frozen and then transferred in a frozen embryo transfer cycle. And we still definitely do eSets in what we call FET, another acronym, frozen embryo transfer.
We need to do a Facebook Live just on acronyms.
Yes.
All right. Thank you so much, Dr. Bartolucci. Thank you for being here and sharing a lot about eSet. That's I know it'll be helpful for a lot of people here.
My pleasure.
All right. So you're welcome. Join us next week for another Lunchtime Live, and be sure to check out our website at yukonfertility.com for additional information as well as a calendar of events to support you and help you feel connected as well. See you next week.